First, I would like to thank you, Dr. Saad, for giving me this opportunity. Good evening, everyone. It's my pleasure to be a member of MEGA Academy and to participate in this webinar tonight. And let me introduce our first speaker tonight, Dr. Mohamed Ahmed, consultant anesthesia at King Faisal University Specialist Hospital in Dammam, Saudi Arabia. Dr. Mohamed is assistant professor of anesthesia and intensive care medicine in Alexandria University, and he will talk about the role of anesthesia in arrhythmia ablation. Dr. Mohamed, the mic is yours.
Thank you, Dr. Azza. Bismillah ar-Rahman ar-Rahim. Today, we're going to talk about ablation of arrhythmias and the role of anesthesiologist. The objectives of this talk, we will start with a brief introduction about the ablation procedures, the mechanism of the ablation, what are the complications that may occur during or after the ablation, what are the challenges related to the electrophysiology lab where the ablation will be done, how to prepare the patient, how to monitor this patient, how to anticoagulate the patient, and how to give anesthesia for patients going to ablation procedures of arrhythmia. What is catheter-based ablation technique? The catheter-based ablation technique is the mainstay treatment for drug-resistant arrhythmias. Many of the arrhythmias that are not responding to medications, the treatment of choice will be ablation. By ablation, we mean we have to do distraction of the focus of the arrhythmia. So we will stop the origin of the arrhythmia, the origin in the myocardium that initiates the arrhythmia. How we can do this distraction? We will do this distraction either by radiofrequency ablation. By radiofrequency ablation, we will insert a catheter into the heart, and this catheter will produce electromagnetic energy, which will be converted into thermal energy, exactly like the diathermy which is used in operating room. And this thermal energy will cause transmural damage of the area ablated from the whole thickness, from the endocardium through the myocardium into the pericardium. And in order to localize this thermal damage to the targeted area only and not to extend the damage to the surrounding tissue of the heart or to the surrounding organs nearby the heart, there will be an irrigation catheter around this ablation catheter. It will infuse and irrigate normal saline to cool down the area of the myocardium around the ablation catheter. So the ablation will be limited only to the tip of the catheter where the origin of the arrhythmia initiate the arrhythmias. Another kind of ablation technique is the cryoablation technique. It is used for ablation of the atrial fibrillation. Also, the radiofrequency ablation used for different types of arrhythmia, including the atrial fibrillation. The cryoablation is less commonly used and relatively more recent than the radiofrequency ablation. By cryoablation, there is a balloon-tipped catheter. This balloon will be filled with nitrous oxide liquid, and the nitrous oxide liquid will be transferred from the liquid state to the gaseous form. And transfer from liquid to gas, it needs to absorb heat from surrounding tissues. So it will cause cooling of the surrounding tissue. When we will cool the myocardium to -75 degrees centigrade, this will produce permanent damage of the area cooled to that temperature. So the origin of the atrial fibrillation usually is coming from the circumference of the opening of the pulmonary veins into the left atrium. When we will insert the catheter into the lumen of the pulmonary vein and inflate the balloon with the nitrous oxide liquid, this will cool the circumference around the opening of the pulmonary vein in the left atrium and will cause destruction of the tissues surrounding the opening of the pulmonary vein, and it will stop the origin of the atrial fibrillations. So these are the most commonly used two mechanisms or two techniques to in ablation of arrhythmia: radio frequency ablation and cryoablation. Arrhythmia may originate from the right atrium or the left atrium. If the arrhythmia is in the right atrium, so the catheter will be introduced through the femoral vein or the internal jugular vein and advance it into the right side of the heart, so the right atrium. Arrhythmias like supraventricular tachycardia and atrial flutter will be ablated in the right atrium, but arrhythmias like atrial fibrillation, it originates, as we said, from around the opening of the pulmonary veins in the left atrium. So the catheter ablation catheter has to the ablation catheter has to pierce the interatrial septum to reach the left atrium, and to guide the catheter during its passage through the interatrial septum, we have to use either fluoroscopy technique or transesophageal echo or intracardiac echo. Usually, transesophageal echo will be done before starting of the ablation because the cardiologist has to exclude the presence of any left atrial thrombus. If there is any left atrial thrombus, ablation technique will be postponed, because if we will do ablation while there is left atrial thrombi, there will be a high risk to develop cerebrovascular stroke. So before starting, usually the cardiologist will insert the transesophageal echo probe. It will exclude the presence of the left atrial thrombi, and it will examine the function of the heart, and he will leave the transesophageal echo probe in place during the whole ablation technique to guide the ablation catheter during its passage from the right atrium to the left atrium. The more advanced guidance is the intracardiac echo. This is the probe of the intracardiac echo. It will be also advanced from the femoral sheath to the right side of the heart, and the intracardiac echo will guide the catheter during its passage through the interatrial septum to reach the left atrium. It will be there in the heart. It will monitor the function of the chambers of the heart. It will detect any complication that happen. It will diagnose if there is any cardiac tamponade due to cardiac perforation, will be detected. If there is air embolism during the procedure, will be detected also by the intracardiac echo probe. The availability of the intracardiac echo will decrease the risk of perforation and will improve the outcome of the procedure. Before also ablation, the cardiologist has to do cardiac mapping, electrical mapping of the heart. By electrical mapping of the heart, he will insert a multi-electrode catheter into the heart. This is the multi-electrode catheter. These are 4 electrodes. It will draw an intracardiac electrogram. So 4 electrodes, one will be high in the right atrium, the second will be in the bundle of Hess, the third will be in the right ventricular apex, and the fourth will be in the coronary sinus. And this intracardiac electrogram will study the electrical conduction of the heart. It will draw the ECG, but from inside the heart. This is the ECG drawn by the high right atrium electrode, and this is by the right ventricular apical electrode. This is by the bundle of this electrode, and this is by the coronary sinus electrode. So the cardiologist, the electrophysiology cardiologist, will study the conduction if there is any accessory bundle for conduction or accessory pathway. Also, through these electrodes, he can do pacing of different areas of the heart in order to identify the origin of the arrhythmia. So during pacing, the heart has to respond to produce the arrhythmias. If we will give any medication during our anesthetic technique that suppress the arrhythmia, any anesthetic that suppress arrhythmia will make the induction difficult. So we have to know what are the medications that we have to give and what are the medication we have to avoid during the electrophysiological study of the heart. A more advanced mapping is the electroanatomic mapping. By electroanatomic mapping, this is the system of the electroanatomic mapping. It produces 3D image of the four chambers of the heart, colored 3D image of the four chambers of the heart. There will be 3 electrodes attached to the front of the chest of the patient and 3 electrodes attached to the back of the patient. And this system, electroanatomic system, will produce a 3D image of the heart. And it will give us an idea about the relationship between the ablation catheter to the cardiac chambers. These spots, red spots, these are the ablation spots. This is the pulmonary veins, 4 pulmonary veins, and this is the left atrium. And these red spots are the ablation spots surrounding the pulmonary veins. By the 3D electroanatomic mapping, the ablation spots has to be contagious. There must not be any gap between the spots, because if we will miss any area in the circumference of the pulmonary veins and we will not do ablation for this spot, this will increase the incidence of recurrence of atrial fibrillation after ablation. That was the technique of the ablation and the electrophysiology of the heart before starting the ablation. Now we have to know what are the procedures related risks and complications. The most serious is the bleeding. And bleeding usually comes from misguidance of the ablation catheter. Instead of it pierces the interatrial septum, it can pierce the anterior or posterior wall of the atrium, causing atrial perforation, and this will lead to cardiac tamponade. How can we detect cardiac or suspect cardiac tamponade during the ablation procedure? If we will find any unexplained sudden hemodynamic instability, we have to suspect cardiac tamponade. In this case, we have to inform the cardiologist that we are suspecting cardiac tamponade, and he has to check with the echo if there is intracardiac or transesophageal echo in place, or even if there is no intracardiac or transesophageal echo, he has to do quick transthoracic echo to detect if there is cardiac tamponade or not. We have to manage the patient by giving fluids, inotropes, and vasopressors. And if there is tamponade, the cardiologist has to insert a drain into the pericardium to drain the blood from the pericardium. Usually the situation will be, in most of the cases, will be controlled, but in very, very rare cases, the bleeding will not stop and patient may need to be transferred to the cardiac OR to be operated. The incidence of bleeding and tamponade is less than 1%, but we have to put it in our mind because any delay may cost the patient life in this situation. What are the predictors of cardiac perforation? This study was done on more than 102,000 cases, 102,000 patients over 4 years from 2013 to 2017. And they found that the predictors of cardiac perforation are female gender, morbidly obese patient, and when the intracardiac echo was not used during the ablation procedure. These are the 3 factors that increase the incidence of cardiac perforation. Another serious complication, but usually it occurs after the procedure, maybe days or weeks, is esophageal injury. We know that the posterior left atrial wall is related anatomically to the esophagus. So ablation in the posterior wall of the left atrium, if it is extensive, the ablation can be extended to the esophageal wall. Days or weeks after the ablation, patient may come with severe sepsis, with air embolism, and with cerebrovascular embolization and hemodynamic instability. This is due to the development of what is called the atrioesophageal fistula. The tissue which was ablated between the posterior wall of the left atrium and the wall of the esophagus will be sloughed, opening a fistula between the atrium and the esophagus. And we have to suspect this atrioesophageal fistula if the patient will come shocked, septic, or with any cerebrovascular or systemic embolization days or weeks after ablation. How to diagnose? We will diagnose it by doing contrast-enhanced spiral CT. We will find that the contrast will pass from the left atrium to the esophagus. Treatment of these cases will be immediate surgery to repair this fistula and close this fistula. And this is the most severe form of esophageal injury. But the mild and more common, the esophageal injury may be less than 0.1%. The incidence of atrioesophageal fistula after ablation may be less than 0.1%. But the more common esophageal complication that happens after ablation is a mild form of esophageal ulceration. And in this case, treatment will be conservative. Can we do anything to decrease the risk of esophageal injury? Yes. We can use the luminal esophageal temperature probe. We can advance this temperature probe through the fluoroscopy, guided by fluoroscopy, to be behind the left atrial wall. And during the ablation, if there is any sudden increase in the temperature measured by the esophageal temperature probe, this means that the cardiologist is doing ablation nearby the esophageal wall. We have to warn the cardiologist to stop ablation at that site to avoid esophageal injury. A lot of studies supported the use of the luminal esophageal temperature monitoring during ablation technique, and it was found that it decreases the incidence of esophageal injury. But some other studies said that esophageal injury may happen without any increase in the esophageal temperature probe. So if the temperature was not raised, this is not a gag against esophageal injury. So before we start, we have to discuss with the cardiologist if he will depend on esophageal temperature monitoring to avoid esophageal injury or not. If we need it, we will put the esophageal temperature probe behind the left atrium, guided by fluoroscopy. Another complication, which is also very rare but significant, is the phrenic nerve injury. The right phrenic nerve passes behind the pulmonary veins. So ablation, especially when we are doing cryoablation of the pulmonary veins, this may cause phrenic nerve injury. How to avoid phrenic nerve injury during cryoablation of atrial fibrillation? We can avoid it if the cardiologist can advance a nerve stimulator into the superior vena cava from the right atrium and stimulate the phrenic nerve, and he will monitor the diaphragmatic movement due to phrenic nerve stimulation, either manually or through the fluoroscopy. In this case, if the cardiologist will monitor the diaphragmatic movement after phrenic nerve stimulation, we have to avoid the use of any muscle relaxant. So as we see, there must be communication between the anesthesiologist and the cardiologist during the operation in order to obtain the best results. Air embolism and the ablation catheter for atrial fibrillation is inside the left side of the heart, so air can be introduced through ablation catheter, causing air embolism. And the management of air embolism usually is supportive by vasopressors, by fluids, by initros, 100% oxygen, Trendelenburg position, aspiration of air. If seen, so another complication that may happen due to ablation is the ischemic stroke, cerebrovascular stroke. Because the ablation is in the left side of the heart, catheter is present in the left side of the heart, so the incidence of ischemic stroke can happen by 0.5%, usually in the first 24 hours after ablation. Although these cases are anticoagulated during the procedure, but still there is a small risk of cerebrovascular stroke or transient ischemic attack that occurs mostly during the 24 hours after ablation. This study compared the incidence of cerebrovascular stroke during the 24 hours after ablation of atrial fibrillation and during the 24 hours after cardioversion of atrial fibrillation. It was found that after cardioversion, the incidence of stroke is 0.3%. But after ablation, the incidence is a little bit more, 0.5%. But an important finding that on the long run, the incidence of cerebrovascular stroke will be less for the patients who did ablation of atrial fibrillation compared to those patients who cardioversion was done to correct the atrial fibrillation. So on the long run, ablation may protect against the cerebrovascular stroke. As we said, for radiofrequency ablation, there is an irrigation catheter that will irrigate fluid around the ablation catheter to cool the myocardium around the ablation catheter in order to limit the thermal energy to the tip of the catheter, ablation catheter. During atrial fibrillation, this is ablation of atrial fibrillation is a lengthy procedure. It takes from 4 to 6 hours. So continuous irrigation of the ablation catheter with normal saline may add a significant fluid load to the patient, especially if the patient has poor left myocardial function. And we have to consider the fluid given during irrigation of ablation in our fluid balance. And we may need to give diuretics at the end of the ablation technique to get rid of the extra fluids. And also we in some cases, if the patient has poor left ventricular function or poor kidney function, patient may develop pulmonary edema, and we may need to transfer the patient intubated, ventilated to the ICU. Pulmonary venous stenosis is a late complication that occurs weeks to months after ablation of atrial fibrillation. It is due to healing of the opening around the pulmonary veins in the left atrium after ablation. It will heal with fibrous tissue, which will cause pulmonary venous stenosis. And this pulmonary venous stenosis will cause back pressure on the lung, will cause congestion. Patient may come with hemoptysis and pulmonary congestion. Incidence is less than 1%. Now we will go to the electrophysiology lab. Where is the electrophysiology lab located? It is in the off-site location. It is outside the OR, usually in the cath lab. The cath lab can be used for both cath lab and electrophysiology cardiac lab. This is the photo from the electrophysiology lab. As we see, a lot of machines, a lot of monitors, a lot of tables, fluoroscopy, and in between all of this, there is a patient here. We may not see this patient. So there is limited access to the patient. Patient is completely covered, surrounded by a lot of machines and monitors and screens and tables. So if there is any complication will happen and we need to interfere, it is very difficult to insert cannula, very difficult to insert endotracheal intubation, to do endotracheal intubation and to control the ventilation in these cases. So this is one of the challenges, the location and the limited access to the patient, one of the challenges for the anesthesiologist. By any means, if we will give anesthesia outside the OR, it will carry more risk to the patient than giving anesthesia inside the OR. ASA in 1994 produced a statement. They put 10 conditions for any location outside the OR has to be fulfilled in order to be suitable for giving anesthesia. And this statement was reaffirmed again in 2018. These 10 conditions, there must be primary source of oxygen, and not only primary source of oxygen, but also we have to have a backup oxygen source. If the primary source will fail, we have to have a backup oxygen source. There must be reliable suction. There must be anesthesia machine connected to scavenging systems. All anesthesia drugs has to be available. All emergency drugs has to be available. In addition to the anesthesia machine ventilators, there must be an ambu bag, and there must be sufficient electrical outlet and uninterrupted power source outlet. If the main electrical supply to the location will fail, we have to have an uninterrupted power source to supply electricity for anesthesia machines and the monitor. There must be adequate illumination, crash, trolley, and defibrillator has to be nearby us. There must be trained staff to assist the anesthesiologist. All the safety codes has to be applied in the outside location, and there must be a post-anesthesia care unit to manage the patient after the procedure. This is the electrophysiology lab. As we see, the table itself is different from the table of the OR. Patient has to lie down flat. Usually the arms will be tucked. Usually the tools for the difficult airway management are usually deficient in the outside locations compared to the OR. If you will call for help for any life-threatening complication that happens inside the electrophysiology lab, your help will take some time to reach to the electrophysiology lab. There will not be an immediate response like if you are inside the OR. So the off-site location itself is challenging for the anesthesiologist, especially when we are doing a procedure that may carry a life-threatening complication that may happen intra-procedure. Although it is very rare, but we have to be ready to deal with it. Otherwise, we may lose the patient. We may lose the patient. How to assess the patient preoperatively? As all patients who will receive anesthesia or sedation, we have to assess the airway, and we have to put in our mind that difficult airway will become more difficult if we are working outside the OR, because as we said, tools are deficient for management of the difficult airway. Trained assistant may not be available if you will face unexpected difficult airway. So assessment of the airway is very, very important. Also, we have to assess the cardiac function. If the patient has congestive heart failure and he cannot lie down flat, we may postpone this procedure because this patient is not candidate for sedation. And if we will give general anesthesia, it may be risky. So we have to discuss this situation with the cardiologist, except if the arrhythmia is life-threatening arrhythmias, like recurrent VTAC or recurrent VF. In these cases, we have to give general anesthesia with intubation and to shift the patient postoperatively to the ICU, and we may carry the risk in order to avoid these life-threatening arrhythmias. Comorbid conditions like COPD, morbid obesity, obstructive sleep apnea has to be identified and controlled before the procedure, because these comorbidities will increase the morbidity of the procedure. Most of these patients are maintained on antiarrhythmic medication, anticoagulants, and antihypertensives, and this is the duty of the cardiologist. He will adjust, stop, or bridge the anticoagulant before the procedure. We have to ask for allergy because sometimes the cardiologist may need to inject contrast during the procedure. And also we have to assess the kidney function because of the contrast and because of the fluids that is used during the procedures. Before the procedure, we have to check our machine, the availability of the difficult intubation tools, the availability of anesthesia drugs, availability of the emergency medications. All this has to be checked because we are walking away from the OR. So every drug or machine or a laryngoscope or video laryngoscopy needed has to be available before we start. And it is better to do conservative management decisions in advance. So if you are deciding to give this patient conscious sedation, but you think that the patient may need to be converted into general anesthesia during the procedure, in the middle of the procedure, so it is better to do general anesthesia from the start and to control the airway and put either laryngeal mask or endotracheal tube from the start. Because during the procedure, it is difficult to do this in emergency situation. Also, it is better to insert adequate venous access from the beginning. If there is any bleeding, there is no time to look for an adequate venous access insertion, and better to utilize all the available monitors that can help you to diagnose any life-threatening complication. Monitoring, the standard monitors has to be applied: ECG, non-invasive blood pressure, pulse oximetry, and end-tidal CO2. Invasive blood pressure has to be used in cases of complex ablation procedures like atrial fibrillation and VTAC ablation. We may insert central venous line, or we may use adequate peripheral venous access. Temperature probe, as we said, we may depend on it to avoid injury of the esophagus if the cardiologist will depend on it. Also, insertion monitoring the temperature in lengthy operations and especially when a lot of fluids will be used is recommended. Urinary catheter, we have to insert Foley's catheter for lengthy procedures that will use a lot of irrigation fluids. We can utilize the TEE or the intracardiac echo to monitor the function of the hearts during the procedure and to detect any complications that may happen during the procedures like cardiac tamponade or air embolism. Our target from anesthesia, we need a patient who is calm, motionless, does not cough, does not move. Respiration has to be smooth, unobstructed, and we have to avoid the large tidal volume during respirations. And the medications that will be used, it has to be, it has not to interfere with the induction of arrhythmia during the procedure, and must not affect the conduction of impulses in the heart. In complex ablation procedures like atrial fibrillation and VTAC, it is better to give general anesthesia. In other arrhythmias like atrial flutter, supraventricular tachycardia, conscious sedation may be enough. Usually there is a debate which is better, conscious sedation or general anesthesia. The conscious sedation has the advantage that it causes less hemodynamic instability. It is less costly. Patient may be satisfied with conscious sedation. Some patients, not all patients, of course. We may not need the presence of anesthesiologist if there is a privileged nurse and a privileged cardiologist doing the procedure. Both are privileged in conscious sedation, so we may not need the availability of anesthesiologists. Conscious sedation, it is easier to induce arrhythmia than if in conscious sedation than if the patient receives general anesthesia. Pain during conscious sedation due to the technique may be warning sign to avoid complication. These are the advantages of conscious sedation. What are the advantages of general anesthesia? During general anesthesia, the airway is secured. The ventilation is under our control. Patient is more satisfied, of course. The cardiologist doing the procedure is more satisfied. If there is any life-threatening complication happen like cardiac perforation and tamponade, we are already controlling the ventilation. Patient is intubated, ventilation. So the element of ventilation will not take from our effort, and we will concentrate on hemodynamic stabilizations because ventilation is already under our control. The most advantage or most benefit that we get from general anesthesia is that it was found that atrial fibrillation ablation done under general anesthesia carries a higher success rate than those which was done under conscious sedation. Why? Because patient is motionless, ventilation is under our control, and the stability of the ablation catheter to the left atrial wall is more stable, and the contact is maintained between the left atrial wall and the ablation catheter. But if the patient moves or takes deep breaths during conscious sedation or coughs, This will dislodge the ablation catheter from the left atrial wall during the ablation process. It will decrease the efficacy of the ablation. To choose conscious sedation or general anesthesia, we have to choose according to a lot of factors. The more complex procedure will need general anesthesia. The more duration that will be taken during the procedure will go to the preference of general anesthesia. If the patient is a child or adolescent, this will prefer the option of general anesthesia. Also, if the patient is very worried, according to the comorbidities associated, according to the preference of the patient, and also we have to take the preference of cardiologists into considerations, because in some types of arrhythmia, cardiologists may request to avoid general anesthesia because some types of arrhythmia will be difficult to induce if the patient will receive general anesthesia. Who will give anesthesia for this patient? Cardiac anesthesiologist or general anesthesiologist? Those who are supporting the opinion that cardiac anesthesiologist is the one who have to give anesthesia for these cases, they build their opinion on the fact that the cardiac anesthesiologists are more familiar with arrhythmias, with anti-arrhythmic drugs, with the inotropes, vasopressors, and ventricular assist devices. And also, if the patient in very rare situation will need to be converted into open cardiac surgery, they will continue the care of the patient. On the other hand, those who support the general anesthetist that has to give anesthesia for these cases, they say that familiarity and skills of the management of hemodynamic instability and arrhythmias are basic skills for all the anesthesiologists. They do not need a cardiac anesthetist to deal with. Also, they say that cardiac anesthesiologist is not familiar with working outside the cardiac OR. Usually they work inside the OR. And also they are not familiar with giving sedation to the patient. Usually they are giving general anesthesia. And also the anesthetic management of cardiac surgery is totally different than the anesthetic management of ablation technique. In cardiac surgery, we will depend on high-dose opioids and high-dose muscle relaxants. In ablation technique, we avoid high-dose opioids because it will cause hemodynamic instability and it will suppress the arrhythmia induction. And also, we may avoid the use of muscle relaxant because of the phrenic nerve monitoring, as we said before. Medications that can be used, ketamine can be used for sedation of supraventricular tachycardia. Sevoflurane during general anesthesia of atrial fibrillation can be used safely. We have limited data for the use of nitrous oxide, but we have to put into consideration that there is a risk of air embolization. So it is better to avoid nitrous oxide in these cases. Propofol for sedation or for induction can be used, but specifically propofol may suppress certain types of arrhythmias. So we have to discuss if we will use propofol. We have to discuss this option with the electrophysiologist before. Also, intermittent or continuous infusion of midazolam, fentanyl, or remifentanil can be used. The drugs that we have to avoid in ablation procedures, especially during the electrophysiological study of the arrhythmias, is dexmedetomidine because it is a strong antiarrhythmic. So it will be difficult to induce arrhythmias in the presence of dexmedetomidine. Anyhow, if we give any medication during conscious sedation or during general anesthesia, and there was difficulty to induce the arrhythmias, we have to decrease the dose of the medications that we give. We have to lighten the anesthesia. We have to shift from one medication to another. If the patient is on a propofol infusion, we have to stop propofol infusion and give something like sevoflurane or ketamine until the arrhythmia can be inducible and the cardiologist is able to do the electrophysiological study of the heart. Ventilation is very important. The aim of the ventilation is to decrease the chest excursion during ablation, because if we will give high tidal volume or large tidal volume ventilation, the chest excursion will cause the atrial wall to be displaced away from the ablation catheter. So the contact between ablation catheter and left atrial wall will be poor, and the incidence of recurrence will be more. So it is better to give ventilation, low tidal volume ventilation, 200 to 300 ml, compensated by increased frequency, and we have to add PEEP to prevent the development of atelectasis. Sometimes the contact or the stability of the ablation catheter to the left atrial wall may not be achieved except by periods of apnea. So we may use small dose of muscle relaxant or opioids and stop the ventilation during the ablation until to increase the stability of the ablation catheter to the left atrial wall. And then after ablation, we have to hyperventilate the patient to wash out the increased CO2. In some facilities, they apply the high-frequency jet ventilation during ablation procedures of the atrial fibrillation, because chest excursion is minimal during high-frequency jet ventilation, and they assume that this increases the success rate of ablation of atrial fibrillation. If we will work inside the left side of the heart, either left atrium or left ventricle, we have to anticoagulate the patient. With the start of piercing or perforation of intraatrial septum, we have to give heparin to maintain the accelerated clotting time more than 300 seconds in cases of atrial fibrillation and more than 250 seconds in cases of ventricular tachycardia ablation. At the end of the procedure, we will do ACT and we will discuss with the cardiologist if he needs to reverse the remaining effect of heparin or not. Because immediately after the procedure, the cardiologist will anticoagulate the patient to avoid any cerebrovascular stroke. After finishing the procedure, we will shift the patient to the post-anesthesia care unit. Most of the ablation techniques for supraventricular tachycardia, for atrial flutter, for multiple BVCs will be done as a day case procedure. In the post-anesthesia care unit, we have to monitor the hemodynamics of the patient. Sometimes the cardiologist will do transthoracic echo to confirm that there is no bleeding and no cardiac tamponade in the post-anesthesia care unit. But in the more complex ablation techniques like atrial fibrillation and like ventricular tachycardia, we will shift the patient to the monitored bed, either in the ICU, in the CCU, in the HDU, for 24 hours. Because during these 24 hours, we have to monitor the patient for any hemodynamic instability and also for any signs of cerebrovascular stroke or transient ischemic attack. After that, patient can be discharged home. The take-home message is that ablation procedures of the arrhythmias need that we have to understand the technique of the ablation, and the requirement for electrophysiological study of the heart during the ablation, and the complications associated with the ablation. And we have to have high suspicion for these complications if there is any hemodynamic instability. We need to prepare ourselves, our machine, our medications, our difficult intubation tools in the electrophysiology lab, because we are working away from the OR. Help will take time until they will reach us, and the access to the patient is difficult. So we have to take conservative management decisions from the start. As we said, if we suspect that the patient we may need to be converted from conscious sedation to general anesthesia, so it is better to do general anesthesia from the start. It's better to use all monitoring, invasive monitors that help in detection of any hemodynamic instability as early as possible, like invasive arterial blood pressure monitoring. We have to tailor the anesthetic plan according to the patient, according to the procedure, and after also discussion with the cardiologist. Thank you.
Thank you, Dr. Mohamed, for this informative lecture. And Dr. Mohamed will be happy if to answer any question from our audience.